Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
I'm really excited and honored to introduce to you this week's guest, Dr. Thomas Levy. Dr. Levy is a retired board-certified cardiologist who has written 13 books that are really incredible, and I would recommend everyone read them. Dr. Levy is considered one of the world's leading experts in IV vitamin C and frequently lectures on this topic. I met Dr. Levy at the American Academy of Ozone Therapy meeting a month or two ago, and in this conversation that I have with Dr. Levy, we discuss some really interesting things about oral dental infections and how they affect chronic disease, particularly cardiovascular disease and breast cancer. Talk a little bit about the devastating consequences of root canal surgery and how you need to really address the cause of the toxin, as well as preventing further toxic load. So without any further introduction, please enjoy this great and educational and super fun conversation that I have with Dr. Thomas Levy. Hey, I'm here with Dr. Tom Levy, and Dr. Levy is a retired cardiologist who is considered one of the world's experts in vitamin C infusions. And you can see in the picture, if you're watching this on the video, we have two of his books up, and we're going to talk a lot about the Hidden Epidemic book. But I believe you've published 12 books or 13?
13 now. This book.
13 now.
Yes, sir.
Was this the most recent book? What's your most recent book?
Rapid Virus Recovery is the most recent one.
Okay. I'll have to get that one. I enjoyed these so much. I'd read your magnesium book a few years ago, and I thought that was really excellent. But we're going to talk about the mouth and how the mouth relates to virtually all chronic disease. And so let's get started and talk about first how you got here so that you were able to write this book. Because I think your personal story is really interesting, and it's woven throughout the text.
Well, I was a traditional cardiologist in Colorado, Colorado Springs, Colorado, back in 1993, 94. And to make a long story short, I got to know an eclectic, probably first real biological dentist, in my opinion, Dr. Hal Huggins, who was working in Colorado Springs. And Dr. Huggins had a huge clinic, and he had patients coming in from around the world. They would come for a 2-week stay in Colorado Springs, all variety of diseases, but he especially, let's say, relished in treating patients with advanced chronic diseases, such as the neurological, ALS, Alzheimer's, Lou Gehrig's, Parkinson's. And he got, to put it mildly, stunning results. So I got to know him at a energy conference in a Tesla energy conference in Colorado Springs, where you might recall Tesla was really big back in the day. And we struck up a conversation. He said, well, come on by the clinic sometime and see what we're doing. So I said, okay. And I remember vividly area filled with patients, and they had this one little old lady, pretty advanced neurologic disease, going into the dental operatory for a whole host of dental work. I mean, extractions, and I mean, just a lot of type of stuff, like I say, when you take the wisdom teeth out of a college kid, they go to bed for a week. Well, I saw this little old lady get more animated, more lively as time went on, and it was just like counterintuitive. And by the time she was finished with her treatment, she was telling her caregiver, "Hey, I'm really feeling peppy now. Let's go out to some fancy place and dinner tonight in Colorado Springs." And about that time, Hal walked into the room, Dr. Huggins, and I said, "Okay, Hal, what's going on here?" And he pointed to the IV bag. I said, "Okay, IVs, I'm familiar with those." He says, "Well, it's what it is that count." I said, "Okay, I'll bite, Hal. What's in it?" He said, 50 grams of vitamin C.
Hmm.
Well, that just was like a left hook to my jawbone. And like any other mainstream physician, if you will, vitamin C meant nothing to me at all, other than the context that, hey, it's a good, healthy vitamin, and you get it in oranges, all the traditional BS we hear in it. But I'm not in the habit of denying what I witnessed.
Mm-hmm.
And literally in that moment, I said to myself, I'm not sure what's going on here, but I'm going to find out. And that began, if you will, a 30-year quest.
Okay. And then I
Because
understand.
later on, Dr. Huggins asked me to come work with him, consultative. And I was more than happy at that point in time, believe it or not, to give up my cardiology practice, because for my own personal satisfaction, I felt I had gone as far as I could with that. And I felt the need to do something else, but I didn't know what that need was until I met Dr. Huggins, and then it became clear.
Now, after you started working with Dr. Huggins, when you started working with him, had you already left your cardiology practice to do that?
Yes. Well, let me. I had tapered it down already.
Okay.
I had issues with one hospital, and there's only two in Colorado Springs, and I just didn't like the work climate there. And I decided I was just gonna dedicate myself to one hospital, but that actually cut my business in half, logically, left me with a lot of time on my hands.
Uh-huh.
And had I had a full bore cardiology practice when I met Dr. Huggins, I probably wouldn't have left it, because you just don't go from prosperity to kind of doing nothing. But in this case, it was already tapered down, and Dr. Huggins offered me a very generous offer on the consultative amounts and the time spent, and such that I actually went and had the time to go to law school, which is another crazy thing. But so no, I had already tapered down the cardiology practice, and I was ready to just leave. And what do they say? What do they say, Stephen? When the student is ready, the teacher will appear. This could not have been a more perfect example of that expression.
No, that's a great expression. The reason I asked you that question was because it would seem that it would be almost impossible for you to learn and experience the things that you talked about that you learned from him in the book without that radically changing how you just did your day-to-day cardiology practice.
Absolutely.
So, well, let's go into, before we talk about some of the specific oral pathologies, let's talk about oxidative stress, because I think one of the things I have to compliment you on this book is there's so much here that just is basic, fundamental, great things that we need, that we've known about, talked about, but never really kind of put it into our day-to-day practice and considerations. And so I thought the way you illustrated things, and then at the end of the book, you kind of just dove down and gave all the highlights of what you explained throughout the book. But let's talk about oxidative stress, because I thought you made a really incredible point that pretty much everybody would agree with, but doesn't really think about it in that way. And let's talk about increased oxidative stress and chronic disease for a minute.
Sure. We start out with the definition of oxidative stress, which is, relatively speaking, in a given situation in the cytoplasm, you have a greater than acceptable number of your biomolecules being electron depleted, which is oxidized, versus being reduced and ready to donate electrons. It's called redox biology, reduction oxidation biology. Well, the thing that gradually became apparent to me, and I think makes the really big difference and perhaps unique aspect of what goes on in that book, Stephen, is that if you go online, if you go to PubMed and you type in oxidative stress plus any disease, you're pretty much going to find papers that say this disease has increased parameters of oxidative stress, blah, 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 all the time. And so the semi-logical conclusion that people come to, and docs, is that oxidative stress causes disease. That's not really technically true, in the sense that when it says it causes the disease, that implies the disease is something else. But the disease is not something else. The disease is the oxidation. You don't have anything going on inside, shall we call it a sick cell, other than what biomolecule is oxidized, where is it located, how is it concentrated, what's its parameters, water soluble, fat soluble. This determines, and enzymes, I mean, you oxidize an enzyme, it becomes inactive. And so when you have oxidative stress that really targets enzymes, then you really have big changes. But bottom line is, you don't have in given cells, like a Parkinson's cell, that cell does not have some additional ill-defined entity known as Parkinson's disease in it. All it has is its own unique array of oxidized biomolecules. And then this brings us to the basic premise of all disease and all remedy. All effective optimal treatment for any condition needs two components: repair the old oxidation and stop the new oxidation. It's really that simple. Not necessarily that simple to accomplish, but that's really all you're trying to do, is repair those oxidized biomolecules, bring in quality antioxidants, donate electrons back to them. But most importantly, and that's of course what the book talks about, is stopping the new oxidative stress. And of course, for anybody that doesn't realize this, a toxin is a pro-oxidant. A pro-oxidant is a toxin. They're synonyms for the same thing. Even though different toxins have widely variable different clinical impacts, the only thing that they do at the cellular level is oxidize biomolecules. It's just, where do they go? How severe do they do it? Which ones do they attack? Which ones do they leave alone? That determines the uniqueness of the toxin's clinical toxicity. But at the biomolecular level, at the pathophysiological level, it's just, did it oxidize the biomolecule or not? Which one did it oxidize? How many of them? And that's all. So you just identify, you repair, and you prevent.
So that leads then into, let's talk about what you call CAP, or chronic apical periodontitis. And can you tell the listeners what it is? And let's talk about the prevalence and how it's related to other diseases, because I think it's really fascinating. And no one talks about this, even dentists. So,
sure. CAP is chronic apical periodontitis, which basically means, very simple, a big not big, an abscess on the tip of the tooth, an abscess on the root.
Right.
When you have an abscess on the root, you have technically a dead tooth. I mean, you might still feel pain, but the pain would be coming from the fact that the root is infected and still viable jawbone. But once the inside of the pulp, which is always going to be the case, ends up feeding an abscess at the tip of the tooth, that tooth is dead. The pulp is necrotic. There's no longer functioning nerve and blood supply, or an interstitial lattice for the immune system to get from point A to point B. And its impact is pretty much the same as the root canal. Okay. And this is something, of course, Dr. Huggins taught me many years ago, that came from the work of Dr. Weston Price. And Dr. Huggins found that by working with Dr. Boyd Haley at the University of Kentucky early on in the late 1990s, they coordinated to have over 5,000 consecutively extracted root canals from dentists around the country, Send them to Dr. Boyd Haley. Dr. Boyd Haley, a brilliant, brilliant man, put together an assay for toxicity. And he found that 100% of these teeth were highly toxic, and it was difficult to dilute the toxins out to the point where they're no longer toxic. He often commented that it was even more toxic than botulism, which, even though we talk about these silly botulinum injections, botulinum is still considered by medicine to be the most toxic toxin that there is. So they also, for the sake of validating it, they tested several orthodontically extracted teeth, which are basically normal teeth, but you're getting them out of there so that the anatomy of the teeth and basically the child or the teenager's mouth can heal in and form a good bite. Those were completely negative for toxins. So we have a situation here where when you look at refined testing, cone beam examination of the mouth, 3D X-ray, really all the root canals have apical abscesses as well. They just tend to be smaller because the root canal procedure does try to evacuate as much of the necrotic debris as possible. But the big mistake here, willing or unwittingly, is that by debulking the infection, you don't really decrease the toxicity at all. So all root canals are toxic. And then the big shocker was, and this is on the cover of the book. On the cover of the book, we see a panorex of the mouth, which shows very, very little detail.
Yep.
And then they have a little circle around one area going down to the cone beam, and you see this huge, huge apical abscess dissolving away the sinus bone. And this was done in a friend of mine. She was going to get 3 root canals taken out at the office, in this case in Denver. And they put up her 3D cone beam and it was like across the room. And I said, oh my goodness, Cindy, I'm afraid you're going to need to have a 4th tooth taken out. And she said, what? I said, well, do you have any pain in this tooth? No. Does it hurt you? No. You have any problems, any sort of ache? Nothing. And that was when the light went on. She had a tooth that was more grossly abscessed than the root canals, but was absolutely pain-free. And then when you look at the literature, not surprisingly, the bacterial, the pathological bacteria, virus, fungi, stamp of periodontal disease is the same for these abscesses. It's because the periodontal disease, in most cases, started the abscess, although sometimes severe decay from above will enter the pulp. Whenever the pulp gets violated with pathogens, game over. The tooth, it becomes technically dead and necrotic, and all you're doing by keeping that tooth inside your body is like keeping something with gangrene attached to your body, which has nothing but enormous toxicity. And then the real bugger was, I talked to a bunch of my dentists and I said, we see this abscess tooth. And they said, it doesn't hurt? No. And then I realized that all the dentists had the same idea that I did, which is if you have a horribly abscessed tooth, it's horribly, horribly painful. Not the case. When I reviewed the literature, I saw in all different countries where they looked at scans of teeth, roughly, amazing figure, roughly 7 to 10% of all adults have one of these abscessed teeth in their mouth. And that might be shocking, but then it might not be shocking when you look at the chronic disease. How many people over 50 or 60 are prescription-free, chronic disease-free, no high blood pressure, no diabetes, no cancer, no heart disease, no fibromyalgia? Practically none. And it's because they all have infected teeth that they haven't identified and they haven't properly gotten rid of. This is also why we look at these little kids. They get leukemia, they get brain cancer. Guess what? They got the same thing. And they need the same attention to the dental work as the adult. I have had 2 young people by email. The parents said, well, what should we do? Our daughter has brain tumor, and the daughter has leukemia, whatever. And I said, well, they need this test, the cone beam. And then they come back and they say, oh, well, and we didn't tell you. I mean, our little girl has had horrible cavities so she basically had a mouth full of infected teeth.
Mm-hmm.
So I said, I'm sorry, don't kill the messenger, but those need to come out. But guess what? When you get rid of that toxic load, remember, reverse the old oxidation, stop the new oxidation. Guess what? Otherwise known incurable diseases rapidly become curable if you stop pouring gasoline on the fire. But bottom line is these CAP teeth, highly toxic, very common, and only identifiable on this specialized test. Maybe the regular x-ray they do in the mouth at the dentist's office might catch 20, 25%, but it's going to miss 75. So we use this example. If somebody walks into your office, do you say, oh, wow, it looks like your blood pressure is up to about 220 over 120 now. We better get you on meds. No, you got to measure the blood pressure. Right. Or somebody walks in and said, oh my God, it looks like you have a blood sugar of 430. No. Well, then nobody walks into your office either and looks fine. And you say, well, it looks to me like you have 2 completely pain-free abscess teeth in your mouth. No, you got to proactively look for it. So that's my main message I have in that book is the 3D cone beam computer tomography examination of the mouth, CBCT, has to be done just as commonly as a biochem panel, a thyroid panel, a CBC, you name it. It needs to be part of the initial basic workup. And if it's normal, great. If it's normal, then you got a great baseline.
Right.
Especially if it's a younger patient that, hey, 30 years, they get to be 30 years old and they develop a problem. They get diabetes, they get a high blood pressure. Then you repeat the test and you see what's happened. In this case, this particular lady, a good friend of mine, did great after those teeth came out. And then, gosh, about 6 or 7 years later, she said, the doctor says, well, I have some lumps in my breast. And I said, oh, well, I said, you know what we need to do? She said, what's that? I said, we need to repeat the damn cone beam exam test because life is not static and disease is not static. And she repeated it and she had 2 more abscess teeth that had to come out. But then she had resolution of the lumps in the breast. Mm-hmm. It's not, in the one sense, excuse me, it's really not rocket science. It really is very straightforward logic. The other thing I like to mention in these, especially abscess teeth that are asymptomatic, oftentimes, not exclusively, they occur in the larger teeth, in the molars, where you chew down with incredible force.
Right.
Incredible force. I don't think that force is matched anywhere else in the body between any 2 structures. Well, guess what? When you chew like that, you not only express pathogens and toxins into the bloodstream, the venous supply, you express them into the lymphatic channels. Mm-hmm. You express, and this is not an exaggeration, but it might sound so at first blush, you express and put pathogens and toxins into the blood and throughout the body more effectively than if you had them in a syringe and gave them IV push. Wow. So that's what especially makes the infected tooth such a deadly entity. Is there's lots of times you can get local focal infections in the body, different areas, soft tissues, and they wall themselves off and they stay put. Okay. And you coexist with your infection, infections in the toenails, infections in the gallbladder, the gut, etc. Or you certainly don't have catastrophic complications. But when you have an infection in a closed space at the tip of the tooth, and that pressure comes down every time you chew, this is why it's the most important single thing to check, no matter what you're doing and no matter who you're treating.
So it sounds to me like you say this isn't rocket science, that almost anybody should understand this. I mean, I knew this before I read your book because I was fortunate to have some colleagues that are let's say basically in your camp where you look at everything, not just your particular subspecialty. But it's pretty patently obvious when you look at your research that you present there, and the epidemiological studies, even the pathology studies with the teeth themselves, where they examined them after they were extracted. Why is it so hard that these dentists just want to take regular 2D x-rays and not this cone beam? Is it because of the cost of the technology to implement it in their practice, or is it a philosophical difference? Do you have any idea on that?
Well, I got to say this, to whatever degree I played a role, I don't know what the role is, but there's a lot more of these cone beam exams out there than there were 10 years ago. I think this has played a role in it. The thing is with the regular dentist, is it just increases their business. I mean, although some of them, I still remember very clearly, this one dentist came up to me at a convention about 7 or 8 years ago. Said, "Well, Dr. Levy, I got the cone beam examination, but there's these little abscesses all over the place. What the heck are you going to do with that?" And I was kind of stunned. I said, "Those are infected teeth. They need to come out." But the thing is it creates more business for the dentist. It doesn't create less business. So why would they do that? I would just say most people, even in the most advanced, quote unquote, advanced professions, have work routines and are creatures of habit. Okay. Mm-hmm. And they've been doing something a certain way for 20, 30, 40 years. And they don't want to change. I mean, they've got it all down. They've got their routine down. But I do have to say this, with all due respect, if I could use the word respect in this, I think the mainstream traditional dentistry profession does more damage and kills more people than anything else on the planet. But to balance that, the biological dentist does more good for the population that he or she treats than any other profession on the planet. So it's out there to be done. You do it right. And I don't mean to be insulting when I say, well, it's not rocket science, but by the same token, is if your arm was grossly infected, has gangrene, you chop it off. I mean, if it's really advanced, there are things you can do where that might not be necessary, but why are you tolerating a clear, gross, advanced infection inside your mouth? Mm-hmm. Is it like you don't think the head is attached to the rest of the body? So the modern dentistry, current dentistry has to come to the plate and become a branch of medicine, dental medicine. Okay, mm-hmm. There shouldn't exist dentistry. There should exist dental medicine. I think the dental schools should incorporate into the medical schools, and you get a degree in medicine and a subspecialty in dental medicine. But you got to realize that everything's connected,
right?
And that's why we're having the problems now. I mean, let me give you a quickie here on why it affects the heart so much.
Yeah, that would be
every time you chew. Okay, every time you chew, boom, pathogens into the venous blood. Well, what is venous blood? Is low pressure. So here's the pathogens, draining veins, low pressure, going on to the capillaries, low pressure, going into the pulmonary arteries, the pulmonary veins, low pressure, going into the low left atrium, low pressure, going to the left ventricle, wham, you go from 7 or 8 millimeters of mercury to 120, 130, 140, 150 in one swap. 25% of your blood supply goes in the coronary artery, and it goes in there with force. Mm-hmm. So you're actually, that's the first spot after those pathogens leave the mouth that they get impacted and impaled, if you will, directly against the side of the blood vessel with systolic arterial force. And we know this because probably, to me at least, the most impressive study in that book comes from 2006, getting on there. It's been around a while. Dr. Ott looked at 36 patients with known coronary artery disease. They had blockages. And he did what's known as angiogram with atherectomy. Atherectomy is basically a arterial roto-rooter. You just literally go in there and scrape out the plaque to open it up. And in, I think it's 38 patients, not 36, he looked at the plaque and he found over 50 species of bacteria, virus, fungi in these plaques in high concentration. And he found them in 38 out of 38 patients. Okay, so that's not a colonization, that's a cause. You did not just develop blockages in your blood vessels, and then for some reason they got colonized. What happens is, literally speaking, we talked about, you have an entity called chronic pathogen colonization. It exists commonly in the nose and throat, but it can also, and commonly does, occur anywhere in the body as a promoter of the new oxidative stress you're trying to shut down. Remember, we want to repair the old, stop the new. So this gets literally in the lining of the blood vessels. You get a proliferation, and then what happens? The blood vessel becomes inflamed. It becomes inflamed because the pathogens are metabolizing and using up the vitamin C. Acute inflammation is an acute deficiency of vitamin C and vice versa. They're the same thing. You cannot have inflammation anywhere unless your vitamin C has just about disappeared at that site. So then what happens is this inflammation triggers an acute immune response. This is very interesting now, because what is the first immune cell to show up at a site of acute inflammation? It's the monocyte, the macrophage, the monocyte. The monocyte has 80-fold, 8,000% more vitamin C in it than the surrounding blood. It's also got a lot of magnesium in it relative to the surrounding blood. It's literally a quota of antioxidant impact that you can't possibly imagine. It's basically a vitamin C delivery system. But the problem is, Stephen, is if the insult in the blood vessel was acute in one time, this acute immune response would heal it. But it's not acute, it's ongoing, it's chronic, 24/7, as like young people like to say. So then the immune response goes from immune quickly to chronic, and then you start your disease process of atherosclerosis.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm excited to announce that we have a new sponsor for the show. Dr. Ed Glazer's Relax, Release, Relief Technique and Training is now a sponsor of the Pod of Inquiry. I call this technique the Triple R technique, and it's truly amazing. He has actually performed it on me. By asking your patient to point where it hurts and have them tell you what motion hurts them, you will know exactly how to position them. They will then lightly push against your very focused light pressure, so minimal pressure that they can barely feel anything. A few seconds later, you will feel a softening of their tissues under your fingers as the patient's skin separates from the deep fascia and suddenly slides. This is the release part of the technique called Relax, Release, Relief. It's a deep relaxation technique that reduces or eliminates almost all pain. 10 minutes after the release, most musculoskeletal pain is gone. The range of motion increases dramatically and permanently for most people. Muscle spasms, including trigger points, are gone. Duration of relief or recurrence is dependent upon the underlying cause of pain, which in most cases has already healed. It does all this by resetting the pain threshold. It's as easy as flipping a switch, and the results are astonishing. I know, I've had the experience myself. What I'm saying is you learn this technique and you'll be able to relieve a lot of musculoskeletal pain from surgeries, trauma, implants, and other diagnoses, including fibromyalgia and CRPS. Dr. Edward Glazer is the inventor of the Soul Support Mass Posture Orthotic and is teaching the lower and upper body in 2 weekend courses. I personally have experienced this treatment, as I've said, from Dr. Glazer, and it does relieve pain, and the technique is painless. Space is limited for these courses to 14 students in each class. Just go to rrrtv.net/course or tap the QR code on the screen to register. You'll want to really do this because it will empower you and give you a technique that really helps people and really will differentiate your practice from almost any other practice. Dr. Glazer's teaching 2 courses. Course 1 is feet to low back, and Course 2 is upper body. Now, the first course, feet to low back, is being offered on October 4th and 5th and November 11th and 12th. And the upper body course is being offered on October 28th and 29th and November 18th and 19th. So go to rrrtv.net/course and get signed up for these today.
Inside the blood vessel, the primary purpose of the vitamin C is to keep a lot of high quality collagen and other connective tissues so that the blood vessel stays strong.
Right.
The worst thing, the body is always going to try to keep it from being killed, keep it from dying. What will kill you very quickly is a ruptured coronary artery. Very easy. Well, if you've lost all the vitamin C and the blood vessel is getting weaker and weaker and weaker, how does the body try to make that blood vessel strong in the absence of new vitamin C? And that's, believe it or not, by building atheroma, because atheroma makes the blood vessel wall thicker. Thicker is stronger than thinner, even all other variables. And then, of course, obviously, it keeps on and on and on until it goes to the point where you block off the blood vessel and you have your heart attack. And there's many other studies now, autopsy studies, that show the plaques also have high concentrations of all these oral pathogens. So my humble estimation is that pathogens from the mouth directly cause, not contribute to, directly cause well over 95% of all heart attacks.
That's astounding. I mean, if you think about, just think about if that was truly acknowledged and implemented, and the proper reshifting of the paradigm, so to speak, would occur. And that's a big, but think about that. It would change the whole way. I'm willing to bet that the amount of statins would be greatly reduced in their prescription numbers.
Well, a lot of the cardiology literature, actually, believe it or not, the cardiology literature has the data backing up what I've been talking about. However, one thing the modern quote unquote cardiologists, my colleagues, finally agree on is that inflammation causes coronary artery disease.
Okay.
But nobody wants to ask why is there inflammation? Or is there a spontaneous presence for no reason at all for inflammation to develop coronary artery? Well, they don't know and they're not asking. But like I just said, it's focal pathogens chewing up the vitamin C and the antioxidant matrix, and then the cascade of immune events. It's my contention, based on this and some other things we won't get a chance to talk about, it's my opinion, based on this evidence, that the primary role of the immune system is to restore a normal vitamin C status where it's most deficient. That's the overriding primary role of the immune system.
Going back to the monocyte who's acting as a mule.
Right, exactly. There you go. I like that. Yes, as a mule.
Yeah. So in the book, you talked about your own personal struggle with some angina and your high-level CRP. You want to chat about that? Because I thought that was pretty interesting.
I'd love to, because it brings me to another major point, which is when all the infected teeth get taken out of your mouth and your sinuses are normal, your problems are not yet over because of the tonsils. Back in the 1950s, Dr. Joseph Issel was a brilliant physician, treated advanced metastatic cancer patients with his own little immune stimulating protocol for cancer, and had pretty good results. And when they all came in, he found, in his words, this is the 50s, no fancy imagery, that 98% of his patients have between 2 and 10 infected teeth. So all of those came out at the outset. They start on the protocol, they start doing better, but he found that a couple months into the program, maybe 15, 20% of them had heart attacks. Now, somewhere in Dr. Issels's brilliant mind, I think he had 1 or 2 patients early on that were having problems that had big inflamed tonsils, not what we're talking about. He had those taken out and the patient calmed down. Well, in this particular circumstance, we're talking about tonsils that look normal.
Mm-hmm.
Okay, we're not talking about the acute, ugly, inflamed tonsils of childhood tonsillitis. Well, in a very radical move, but a perfectly correct move, Dr. Issels began doing tonsillectomies on all of his patients after all the teeth that were infected came out. No more heart attacks and tremendous improvement on his cancer statistics. And in Dr. Issels's words, 100% of these tonsils upon pathology were grossly infected with pockets of pus, nowhere near close to normal, even though they appeared normal and looked normal. So you got to remember, when you have something in line in your jawbone, the tonsil drains it all.
Mm-hmm.
And a root canal or a CAP abscess tooth is a nuclear bomb's worth of infection. I mean, the tonsils can deal with little low-grade amounts of pathogens. You hit it with a steady, nonstop, 24/7 stream, they become chronically infected. But the really deadly part, if you will, is when the tooth comes out, the tonsil doesn't cure itself. And that's, so with my particular experience, this is about 7 or 8 years ago now, I had been struggling with the CRP, as you read. And as a cardiologist, I know that really put me at high risk of a heart attack. I tried so many different things to get it down. I had had a root canal put in 20 years earlier and had it extracted 10 years from this point in time. So my mouth was free of that root canal tooth for 10 full years.
Sure.
And so my little dog gets chased by a big dog. I run across the yard, boom, chest pain. So I said, oh my God. So this is what it feels like. You're the cardiologist. Now you're the patient.
Right.
And I just said, well, I'm going to sit down and I'm probably going to either drop dead in the next few minutes or it's going to go away. And it went away. And I immediately thought of Dr. Issels's work. And I said, I don't care what these tonsils look like. They're not staying in my head for one more day. I called the ENT surgeon the next day. And of course, you don't need to do much to convince a surgeon to operate. I just completely lied and said, hey, I've been having tonsillitis all my life. They're really settled down right now. Let's get them out there while we have the chance. And so we scheduled it, did it the next day. And here's the interesting part. I had had 10 years earlier the root canal on the left side of my mouth. So post-op, he comes by, how you doing? I said, well, pretty good. I said, do you find anything interesting? And he said, well, it's interesting that you asked that. I said, why is that? He said, well, when I took the forceps and grabbed the tonsil on the right, everything was fine, and we cut it out. And then when I went after the tonsil on the left side and grabbed it, pus started coming out.
Mm-hmm.
And then he pulled it out. And then my CRP came down into normal levels for the first time in 15 years or so. But the thing I want to leave people with that are listening to this, and they'll find it in the book, is that the tonsils must be extracted or treated. And now it does appear that there are treatments that work very well. So you don't have to run straight to a tonsillectomy, which I will acknowledge was an absolutely awful experience, worst of my adult life, I guarantee you.
Yeah.
But the tonsils are harboring the pathogens. We now know that injections of ozone gas directly into the tonsils heals them very nicely in just about everybody. People can look and see if they have an elevated CRP, inject the tonsils, and see if the CRP comes down.
Mm-hmm.
Methylene blue drops, believe it or not, on top of the tonsils is a powerful anti-pathogen agent. It goes throughout the tonsil very quickly. And I would do both.
Mm-hmm.
I would do both. And I would make sure that CRP number was in a solidly normal range. I will say right now that if you end up having this done and your CRP still is staying high, I'm not sure of any other screening test to know that it's something other than the tonsils. And then you should seriously give consideration to tonsillectomy, because you're just keeping huge pockets of infection inside your body that are seeding these pathogens. And the other thing, the tonsils also seed the chronic pathogen colonization that we get in the nose and throat, that we won't have time to talk about here, but I covered in my book, Rapid Virus Recovery, that has to do with how we led into the pandemic and how we can get out of it. But bottom line is, you have to take all of the chronic sources, depots of infection out of the mouth. And you can't ignore the sinuses. Why do I say that? And you wouldn't if you did the 3D cone beam, but something I think the ENT doctors either don't know or ignore, or I don't know, because it's in their literature too. But how often does the ENT doctor treat chronic sinusitis? Well, I'd say that's probably one of his bread and butter type things, do different procedures, different medicines, etc. Well, this one study showed that fully 70%, 7 out of 10 patients with chronic sinusitis have one or more infected teeth in their upper jaw, the maxilla, abutting the sinus. Again, you're not going to get anything accomplished until you get those teeth out.
Right.
But obviously the cone beam will reveal the ones both in the bottom and in the top. So that would take care of that. But it's still just amazing how, I'll try to keep it scientific, that there's just so little attention to science in what we do. I mean, we form habits, and we don't want to change our habits come hell or high water.
Right. Oh, it's well, and then if you add on the third-party insurance demands that won't let you do some of these things because they're not recognized as being anything other than, experimental at best, woo-woo at the worst, and so you have those elements pulling at people. But invariably, and this stuff is not new. It's been around in the literature for a long, long time. It's not like it just popped out a year or 2 years ago. But
Weston Price established the severity of focal infection back in the 30s and 40s, and it was rock hard science. I mean, rock hard science. And I mean, he killed a lot of rabbits showing how it worked. But I got to tell you, he would take a root canal out of somebody, let's say, that had coronary artery disease, tuck it under the skin of a rabbit, and the rabbit would die in a week of heart attack. And he would and then he would take the same tooth, same one, out of the dead rabbit and put it in a new rabbit. And it would kill 30 to 40 consecutive rabbits, all with coronary artery disease. He did this similarly with arthritis. Same thing, crippling arthritis. What is interesting, though, is apparently, although it's never really been nailed down to my knowledge or satisfaction, apparently these pathogens do have organ signatures. They do have areas of the body, tissues of the body, that one pathogen or one group of pathogens prefers over other areas.
Okay.
Bottom line is, you don't need to worry about that. You just need to get the mouth cleaned out as complete as possible and not get sidetracked on. I mean, there's talking about the meridians of the teeth, and I think that has some validation, but not to the point that you just don't realize whatever meridians it's on, maybe it hasn't caused breast cancer yet, but it will still cause breast cancer if you leave it in there long enough, even if it's not on the breast cancer meridian line.
Mm-hmm. And if you think about this, and as you point out, regardless if it's cap or if it's just an osseous cavitation or whatever. You have to think about this is it's a repository to just pump out this toxin into your systemic circulation every beat of the heart, every bite of the ribeye. And so yeah. and then we think about, okay, so we've got the gut microbiome, right? So how can the gut microbiome, because some of this stuff has to also go down probably salivary wise into the gut. So I would think the gut microbiome and the oral microbiome are a little bit more closely related than maybe a lot of people want to talk about. But everybody says all things begin at the gut. Well, maybe all things begin at the gut because they really started in the mouth.
Absolutely. And you just nailed it. You nailed the essence of rapid virus recovery. I almost called the book Rapid Gut Recovery, but we were starting in the middle of the pandemic. And I said, well, it's more important to put a focus on how people can get over viral infections, including COVID, than how they can start resolving their gut issues. But the techniques in the book went after both things. So this chronic pathogen colonization that I'm talking about is present in every person who's ever had a cold or flu or infections in the mouth and has not yet done a biofilm stripping pathogen killing remediation. There are lots of different things you can do, but the best one is hydrogen peroxide nebulization. That strips off the biofilm, kills the pathogens, and in many people, within 24 to 48 hours, they start having more normal bowel movements than they've ever had in their life.
Which
this is the gut. Go ahead.
Well, I was going to say that's an important thing, because what you pointed out into your book is that one of the detox systems of our body is the fecal transport. And if it's constipated or, days or 2 days or whatever, it can be very, very toxic. So yeah, I just wanted to.
Well, you don't have a truly normal bowel movement if your microbiome is screwed over or if you have a leaky gut. The other thing I noted and found in the literature is that the epithelial barrier cells in the gut that prevent stuff from going directly into the blood have a half-life of 3 to 5 days. So they have stem cells in there that are turning over the gut cells literally every week.
Mm-hmm.
Meaning that these chronic gut conditions are not chronic conditions at all. They are chronically induced acute insults. Mm-hmm. Because what happens when you swallow these pathogens? Okay, bunch of things happen. Number one, the pathogen itself goes down to the gut and starts forming new pathogen overgrowth in the microbiome. Number two, there are exotoxins. Number three, there are endotoxins, depending on the pathogen. Number four, there are metabolic byproducts, all of which are pro-oxidant. And number five, the coup de grace is when the pathogen dies, it ruptures and releases a huge amount of the most pro-oxidant substance on the planet, which is iron, mm-hmm. ferrous iron. All pathogens thrive on iron. The more iron you put into the system, the more the pathogen thrives. They've actually shown that the effect of some of the best antibiotics that we know of for certain bacteria is that they're iron chelators. So they pull iron out of the environment and the pathogens can't thrive. But remember, get back to the disease. What causes all disease? Increased oxidation. And all of these things are just screwing the gut up royally. I had a young man, his mother started the peroxide nebulization. And then within a couple months, he completely resolved, cured, got over Crohn's disease. And got out of bed, stopped all his medicines, became active in school, gained weight, started playing sports, and never had an abnormal bowel movement again with just the peroxide nebulization. Okay. Wow. Another lady wrote me in a letter that said it cured her entire family's black mold illness. They had already moved out of their house. They've been hospitalized many times. The kids have been in the intensive care unit. They tried everything under the sun. And the lady said, after the first nebulization, I couldn't believe how much better I was already. So the thing is This is the answer. I mean, I don't want to sound too egotistical here, or it's not me, it's just science. This is the answer. You see, and the other thing too, this is the answer to all chronic disease. Why? I make the statement now in my presentations. I don't care what you are treating for what condition with what you're using. Don't treat anything with anything unless you include hydrogen peroxide nebulization in the regimen, because you got to strip out that biofilm. And in most people, the gut just gets so much better. And there's no topic, as you well know, right now that's being more discussed than how badly an abnormal microbiome and leaky gut screws up the rest of the body. Well, it's true,
Right.
It does.
Right.
But the thing is it's not hard to get over it. The thing is we get off on tangents. Probiotics, most probiotics are useless. If, on the other hand, you have a probiotic that you like, that you can afford, that you feel makes you feel better, fine, go ahead with it. But the thing is stop just hitting the repair side of disease treatment and go to the prevent side of the disease treatment. Dr. Huggins told me many years ago. He was a very sarcastic man. I loved it. And he looked at me one day and he said, "Tom," I said, "Yes, sir." He said, "Don't you realize you can't dry off while you're still in the shower?"
Yeah.
And
that's a beautiful metaphor.
It's profound.
Yeah, because think about it. If you really take what we've just discussed seriously, and I don't see how anyone who reads this book that has, any semblance of cognizance in them could argue with it. It really kind of says to me, we need to shake up the way we're treating and looking at peripheral neuropathy. We need to change, a lot of these things. And why start with the gut microbiome if we have something that's setting that off, right? So this knowledge, this science is there and it's real, but there's a problem with it. And that is it's disruptive to the current status quo. And maybe that's...
Well, there's another thing too. I did a video on this 30 years ago, and I thought by this time so many people saw it. And I just gave a conference to about 30 people, 35 people, and 2/3 of them, 3/4 of them had never heard of this. So I'll make it in a nutshell. In our enriched food, quote unquote enriched, since the 1940s,
yep,
I think they add a couple B vitamins and iron. They add iron. They add iron, believe it or not, in the form of metallic iron filings.
Mm-hmm.
You can pull them out of the cereal, dance them around. Now, what do we just say is the worst possible thing for your gut?
Right.
Iron. So for anybody who's not has the money to have a organic diet, they're getting a huge amount of chronic gut irritation from a dozen different points of view from this chronic iron ingestion. I mean, I'm not even going to go into how stupid it is or what the possible motivation could be of these people. They either want to kill the population or they're too stupid to understand that that's not what they're doing.
Yeah, right. You could make the similar argument with iodine supplementation as well.
Well, I'm less familiar with that, so I wouldn't attempt to go pro or con on that one.
Well, I'll just share it real quickly with you. And,
all right.
I had a guest, Dr. Alan Christensen, who is a naturopathic physician who's really an expert in many things, but thyroid is one of them, Hashimoto's particularly. And he showed in his book, I guess it's called The Thyroid Reset, that and they have there's countries like Denmark. The Denmark Health Agency had some really great epidemiological studies where they showed the incidence of Hashimoto's going, just extrapolating very, very quickly after they started adding iodine in their all of their supplementation. And so it was just fascinating. But I mean, that's pretty well known. And again, a lot of the science demonstrates this, but there's either an ignorance or there's just, I'm not going to look at that, or I want to keep it out of mind, or some type of cognitive dissonance. But it seems like the same thing with iron. I mean, I mean, you made a point in the book. One of the things you need to look at with these folks is ferritin, and what is their ferritin level, and it ideally should be a lot lower than what 100 is considered okay or below now, I guess. But I think you pointed out it was like 30, and
Right. Some laboratory ranges have quote unquote reference range, normal range up to 400. Hey, if you have a ferritin of 400, you better have your spot reserved in the hospital to get your coronary artery bypass.
Yeah. So anyhow, I don't know how we kind of got a little bit tangential on that, but I think what you're showing here is that we need to reshape our paradigms. And I don't care if you're the nephrologist or if you're the gastroenterologist or if you're the podiatrist treating that neuropathic condition. We're not just we shouldn't be just symptom treaters. We actually should be symptom cause finders, and then maybe treat both symptoms and the cause if we can. And so I think what you bring is so valuable. And I wanted to comment on the hydrogen peroxide nebulization, because I was introduced to that by Frank Schallenberger a few years back. And he said, basically, anytime you feel like you're getting a cough or a cold or anything like that, start hitting it. I can't tell you.
That's right.
It shuts it down instantly. You just don't get sick when you do that. I mean, I can't imagine why that's not more known.
Well, hydrogen peroxide is actually one of those abundant molecules in your body.
Right.
You have water, H2O, oxygen, O2, and you have hydrogen peroxide, which is H2O2. And the respiratory lining cells in the lungs actively secrete and express peroxide into the airspace to naturally deal with every pathogen that you inhale with every breath. Obviously, when you get too many, it overwhelms the process and you need to help it. But you're helping it with the most natural process that the body possibly has. It only leaves behind the two nasty agents known as water and oxygen after it kills the pathogen. So what better situation do you have to heal previously infected tissue than by hydrating it and oxygenating it? And then furthermore, the hydration helps you clear the debris and cough out whatever pathogens you killed in the process. It's absolutely the most natural, ideally designed anti-pathogen system there is. A lot of people say, well, what about this? Can I nebulize this? Yeah. Will it help? Probably so. But why are you trying to improve on a perfect remedy? A perfect remedy that's not only cheap, available. So, but the point is well made. Nebulization is a much underused way of getting of getting a lot of nutrients inside your body, of maintaining pathogen-free states. Much underutilized.
All right. Well, listen, I can't thank you enough for taking the time. I want to thank you for writing these books. I know that there are some people that they're gonna really get into this once they just get a little tickle, like, hey, go read these books. But I want to thank you for writing the books and taking the time to come on. I could probably spend another 3 hours with you talking about what you talk about in supplementation and all these other things. And maybe we have another conversation down the line, because I think that's a barrier to entry for some of the colleagues that I have that are in practice. So anyhow, thank you so much. And wonderful. Keep producing the books. Do you have another one coming out?
Not imminently, but it's going to be roughly something along the lines of the cause, the cause and the resolution of Alzheimer's disease.
Okay.
Because I've seen this pattern developing over the past 30 years, and really all I have to do is summarize it and put it into one volume.
Yeah, that would be great. And then how can folks get a hold of you if they want to contact you, get your books, that type of thing? I know your books are on Amazon.
Anybody can have my email. That's Levy MD, TELEV as in Victor Y, MD @yahoo.com. And I don't do consults, but if I have questions, I can push them into different information. I can give them downloadable books and articles. And also they can go to my website, which is peakenergy.com, which has a lot of information on it as well.
Okay. Dr. Levy, thank you so much. I really appreciate it. And it's an honor for me to have you on the show.
Thanks for having me, Stephen. I enjoyed it. Thank you very much.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardio protection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pot of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pot of Inquiry. Use Pot of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pot of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pot of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.